We'll proceed to the next session, which is titled Metabolic Surgery. And I have the pleasure to introduce the four world-class doctors, and Dr. Carel Le Roux, Dr. Camilo Boza, Dr. Miras, and Mr. Dimitri Pournaras. The title of the session is very interesting. Metabolic surgery is dead and long live metabolic surgery. So when I asked Dimitri about the title, I was not sure I could make out, but let's see what he has got in his mind. All to Dimitri, you.
Oh, thank you, everyone, and welcome to the session on metabolic surgery. The fact that we have this title is perhaps a reflection that metabolic surgery is the jewel in the crown in this field. So it's a pleasure to have Camilo, Carl, and Alex, and without further ado delay, we'll ask Camilo to start by introducing the concept and talk about why the referral rate for metabolic surgery has not changed as much as we expected. Camilo.
Camilo, you are on mute, please. Unmute.
Here we are, sorry.
We can see
we can hear you now, Camilo.
We can see you and hear you and see your slides.
Okay, thank you very much. Sorry for the delay. Thank you, Dimitri, and thank you all the organizers. This has been really a very tough talk because there's basically very few data, but I cannot agree more on what's happening on this field, and it's really an honor to be here. I'm definitely not the most expert in this. However, I do a lot of surgery, and I'm still really missing the patients, and that's what we are seeing. And even after with the pandemic, that we've seen a huge rise in patients in many ways, we are not seeing more metabolic surgery. This is 2011, a big series, 10-year follow-up. Kelvin Higa, probably one of the best surgeons of the world, on the West Coast in the US with very obese patients, and 20% of those patients were undergoing bariatric surgery with diabetes. That was 2011. And then we jumped to almost a decade after, 10 years after, with the 2019 data of the LIBSS registry, almost 1 million cases. And this is what we see. We see even in Australia, around only 10% of the patients undergoing bariatric surgery having diabetes. In Chile, not more than 20. Even in the UK, only a bit more than 20. And if we separate in the different chapters of the world, we see that at least in Europe, you have more patients undergoing bariatric surgery because of diabetes. But then you have to go back on the structure of the health system, where if you have a more socialized system where you basically take care of the most complicated patients, so basically doctors are making decisions, you see probably more diabetics. But here in Chile, for instance, where bariatric surgery has been performed in the last decade, basically in the private environment, we can see as low as 5% of the patients undergoing bariatric surgery having type 2 diabetes. So something's wrong here. And if we go to the Diabetes Surgery Summit, this is the picture, 2007. Many of here in the session are in these pictures with quite much more hair at that time. And basically what happened there after, many years after, in London, with same thing, Diabetes Surgery Summit, new guidelines, diabetes care, dozens of papers published in the DSS in diabetes care. The data from Phil Stampede trial, stunning results of surgery, sleeve or bypass, whatever you say, much better than medical treatment for treating diabetes. The effect of bariatric surgery, even in the long-term survival, compared in the long-term studies from SOS study and any of the long-term studies, and many prospective randomized trials definitely achieving better results than medical treatment. Probably in not even in many of the medical fields, you see so many trials like definitely having such a difference between surgery and medical treatment. So then we came to 2019. We came back to New York, where the Fourth World Congress, the vessel was opened in March 2019 in Hudson Yards in New York, and things were fantastic. We thought that we were having better things. But the year before, we had met with Carel and all this group in a nice chateau in Loire, discussing all the things about what was happening with metabolic surgery, and we thought things were going to be better for the meeting. But at the end thing was stigma. So something's happening that we don't want to treat our patients, and for some reason, patients are not. And then you have to go back to what stigma means, and what definitely thinks a bigger group identifies something in a minor group and then start chasing it. Definitely the group isolates the stigmatized minority and start to potentiate the characteristics they define. And this study is interesting, how referrals are structured in the primary care physicians. So here it's amazing how, look here, I'm comfortable informing my patients about various bariatric surgical options. You have as much as 25% of healthcare professionals not being comfortable speaking about bariatric surgery. Obesity in patients with BMI over 35 can be managed effectively without surgery. Almost 25% of the healthcare professionals can advise patients not having surgery or having other options rather than surgery, even with more than 20 or 30 kilos of overweight. Almost half of the healthcare professionals were not even familiar with NIH criteria or any of the criteria for bariatric surgery. So basically, finally, stigma, what happens is basically patients are not complying to treatment, delayed consultation, guilt and judgment, and basically no referrals. Here's interesting, it's a paper just published here in Chile, where they asked 1,000 patients with obesity and 20 healthcare workers. And here, if you say, they ask, why do you think you are obese? And when they ask the patients, almost 50% of the patients in blue there, my lack of ability to control my hunger. But the healthcare professionals thought that even 75% of the healthcare professionals thought that it was a lack of control of hunger, or 94% of the healthcare professionals said that their preference of unhealthy food. And the patients, basically, they don't feel as guilty as the healthcare professionals that basically are blaming the patients on their condition. So here, when we see what's happening in stigma of bariatric surgery, 50% thought people had weight loss surgery for cosmetic reasons. However, when you ask, do you think there's not enough provision, most of them say, well, there's not enough treatment for obesity. However, here you see that almost 30% of healthcare professionals think that severe obesity can be treated by lifestyle changes. Even type 2 diabetes can be treated only with lifestyle changes. So So at the end, it's basically the reasons of bias, misconception, or limited understanding of the condition. And there's a huge gap between science and the conventional ideas. The other thing is that obesity and diabetes, everything is like blamed on prevention. We should focus our efforts on preventing obesity rather than spending money on expensive therapies for morbid obesity or diabetes. But when you put this on AIDS, for instance, here it happened in Chile, AIDS is fully treated, fully covered by all of the insurance, public, private, everything. We should focus our efforts on preventing HIV rather than spending taxpayers on expensive therapies for AIDS. No one would ever dare to make that statement, but we do it every day for obesity and diabetes. So at the end, what's the consequence of this is that we are seeing that although obesity is much more prevalent, the gap for funding is huge. We have a lot of funding for cancer, a lot of funding for HIV, but very little funding for obesity and diabetes proportionally. And finally, just to finish and to let our colleagues to make their points, I think the other new wave now coming on, not stigma, but at least for metabolic surgery, is the confidence on new drugs. Still, complications of surgery is something that I think endocrinologists and diabetologists fear a lot, and lack of information. Probably when you see all the new papers coming with empagliflozin impacting even mortality, it's definitely something that makes the referral even more delayed because we have more drugs, we have more treatments. So what we should do, I think we should leave that for discussion, but I think social media is the way to really get to the patient, at least in the surgeon's perspective. You know that 95% are having access to any form of things. I think it's very interesting, the things that are being done in many of
history gives you your story. This time will be different.
this is many
Weight loss surgery can't help over.
all of these influencing structures to get to the patient and to really have more access. Here in Chile, we've done many activations with patients that have been really important in social media or on TV shows, on things. And this is the way to get to finally the patients. But my conclusion is that referrals have definitely been stable. And I think the stigma is totally in the healthcare professionals, patients and community. And we need to start speaking about the language and probably getting for politics. And now I think with cost effectiveness, because probably with new drugs, we are going to achieve better results. However, the cost of the disease is going to be definitely very, very expensive. And probably with surgery, we are going to have a better outcome. Thank you very much.
Thank you, Camilo, for a brilliant talk, really thought-provoking. Years ago, you told me that a statement that has really influenced me massively since, that we have tried to win people's minds, but we need to win people's hearts so that we can actually get metabolic surgery across. And you made a great point about social media. Any other thoughts on how can we do that? How can we win people's hearts?
I think that we are getting to the heart of the people, but we are not getting to the heart of diabetologists. I think that's our main thing now. I think with new drugs now, with empagliflozin, with GLP-1 analogs here, they feel now they have new tools. So now it's like a matrix reloaded. And I think now, based on the drugs and things, they feel that they're going to have better. And when you show all the prospective randomized trials, they say, oh no, they were done with metformin, so now we have the super drug. So all those randomized trials are crap. So at the end, it's a never-ending story with that. So I'm not sure we're going to get to the heart of the diabetologist, honestly. So in my surgeon's perspective, I will continue to conquer the heart of the patients and make them come straight to me and not as a referral. That's my humble.
Thank you, Camilo. Thank you. This is a really controversial sort of session anyway. So the first thing I'll say is that you assume that diabetologists have a heart, which is first of all a very good sign. So I'll ask Carl and Alex, who in a session, for their thoughts and comments on that.
Camilo, great talk. Really enjoyed that. So maybe you can just say, that it has been challenging to speak with diabetologists, but what do you think we have done wrong from the surgical community when we communicated it? Is there something that we can do better?
Yes, I think that's a great point. And surgeons, well, you saw the talk, and I never blame myself for anything. So that's a very bad thing that surgeons usually do. It's the way to survive in the OR. So, but I think we've been very inconsistent on offering options. Surgeons tend to be. You are a bit more protected in Europe, but here in Latin America, you pick a stone and you find a new surgery being offered. But some, as I always remember, Dr. Kaplan saying that naming the chef around here in Latin America, that you can add a surgery, you choose this, and then you put something from here, and you add a spice there, and you're gonna have like making surgery like a nice plate of food. So I think that's probably the main thing we've done wrong. We should choose one simple procedure to say surgery. This is it, and we should focus on that and not keep on like asking, "Oh, this is a duodenal switch, bypass, leave, etc." And I think that's a wrong thing. We should say we can achieve a good weight loss, and that's gonna be beneficial for diabetes.
Alex, I thought a comment.
I think we should move on. I'll make some comments later on. The other thing I have to say is that I'm very jealous of Camilo's consulting room. You can see the difference between his and mine consulting. He's in the 5-star, I'm in the 3-star. Shall we move on to Carl?
Yeah, let's do that. So, Carl, novel pharmacotherapy for obesity and type 2 diabetes is going to challenge the status quo. Looking forward to that.
Thank you very much. I'm just having some challenges sharing my screen. So I'm not sure if somebody can give me control so I can just share my screen. I have control. Perfect. Perfect. Okay, good. I've got control. Thank you very much. So I'm starting with this famous painting that hangs in the National Gallery in London of Copernicus. And, he was trying to convince people, in fact, that the Earth was not the center of the universe and the sun did not rotate around the Earth, but it was the opposite way, that the Earth rotated around the sun. So some of the challenges that we have now with the new medications coming along is a little bit like Copernicus, where we have to redefine, because what I hear so often is people saying that the new medications is going to reduce the number of operations that we're going to do or replace the number of operations. And I actually think exactly the opposite is going to happen. The new medications is going to increase the number of bariatric surgeries we do. And I'll explain to you why I think so. This is my disclosures, and we work with lots of different companies, pharmaceutical companies, surgical companies, and nutrition companies, because we don't think that there's one silver bullet for the treatment of diabetes and obesity. We need all these different options and very often need them in combination. So I think it's been helpful to us to define at least which organ we are treating when we are treating a patient with obesity and diabetes, that we are focusing on the subcortical areas of the brain, because this is where our surgery has the biggest effect. So even in people with diabetes, we hear that patients say, I feel less hungry, I feel more satisfied, And this is also where the medications are working. So if we use a nutritional therapy, a pharmacotherapy, or a surgical therapy, it all works through this common pathway, and our patients report feeling less hungry and more satisfied. Now, let me get to some of the medications that we have at our disposal. We have liraglutide, which shares 97% homology with native GLP-1, and we have semaglutide on the right-hand side that shares 94% homology with GLP-1. So what do these new medications hold in store for us? I'm going to focus on the step 2 study with semaglutide in people with type 2 diabetes, where patients were randomized 1:1:1 to either placebo plus diet and exercise, semaglutide 1 milligram plus diet and exercise, or semaglutide 2.4 milligrams plus diet and exercise. And this is 1,200 patients recently published in the Lancet. And what you would see, what we get for the first time, is double-digit weight loss in people with type 2 diabetes. Now, you'll be aware that people with type 2 diabetes lose less weight than people that don't have type 2 diabetes. But looking at these curves, we see a dose response curve. So semaglutide 1 milligram, which many of us already have in our clinics, is very good, but semaglutide 2.4 milligrams is even better when it comes to weight loss. You'll also see that the weight loss only start plateauing approximately at 1 year. But it's the categorical weight loss that's so interesting. We can see that more than 13% of patients lose 20% of their weight. Now, certainly with bariatric surgery, we have 90% of people losing 20% of their weight. But this is remarkable that we can have such a significant outcome in people with type 2 diabetes. When it comes to blood pressure controls, we see improvements that's very similar to what we see after bariatric surgery. So the additional benefits of these medications are going to be substantial. And certainly when we look at glycemic control, look, this is people going from a hemoglobin A1C of 8.2 down to a hemoglobin A1C of 6.4, dropping below the diagnostic threshold for diabetes. And you know, we see 2% reductions with surgery very often, but these drugs are going to be almost as effective from a glycemic point of view. But we also see what we see with bariatric surgery, this improvement in quality of life, predominantly driven by the physical domain of this. Now, these drugs, exactly like surgery, do not make people thin and they do not make people happy. But what they do is they make patients healthier and more functional. And thinking of it in this way will also help us position this within our clinics. Something that we've seen with bariatric surgery for a very long time is this dramatic reduction in CRP, in inflammation. And we think that many of the benefits that surgery bring has to do with this reduction in inflammation. But look now, we see almost a 50% reduction in CRP also with semaglutide. And this appears, like many effects of surgery and semaglutide, to be weight loss independent. So these are effects that we see beyond weight loss. So what's a new drug in town, just been published in the Lancet this week? This is an amylin analog that also works on the same part of the brain. This was a phase 2 study, as I said, just published in the Lancet, showing us a dose response effect. And what you will see, this is only a 6-month study. And you can see with the top doses, the patients are still losing weight. So they haven't plateaued yet. But even at 6 months, we're getting 10% weight loss, which suggests to us that we may get to 15% weight loss on average at 1 year. Again, data very similar to what we see with semaglutide 2.4 milligrams. Again, looking at the weight loss, the categorical weight loss, more than 20% of people getting 15% weight loss. Certainly weight losses that we've seen also with gastric banding in that regard. These drugs do have side effects. And again, their side effects are very similar to what we see immediately after surgery. So most patients after surgery have a level of nausea that settles down. Most patients after surgery have some constipation that we need to manage. Most patients after surgery get, not most patients, but a risk of about 3 in 100 of patients can get gallstones. So we see these GI side effects very similar to what we see after surgery. Now, our diabetology colleagues are not focusing on this. They haven't listened always enough to the experience that we've had with surgery. So we're going to reinvent the wheel, unfortunately. And it's important that we help our diabetology colleagues manage the side effects that will happen if you've got 20% weight loss, because in surgical space, we are used to these effects and we can manage it quite easily. And again, we will have to teach our colleagues. But it doesn't take a rocket scientist to suggest that what happens if you combine semaglutide with cagri in this instance. Now, this is a phase 1 study. This is only done for safety. And patients were given a dose response. They all had semaglutide 2.4 with increasing doses of cagri. And what you will see at 20 weeks, patients lost 17% of their body weight. Now, this, if you look at these weight loss curves, this looks like a sleeve gastrectomy or even a gastric bypass. And you can see these curves have not settled down yet. So this combination may well result in 25% weight loss in our patients. Again, there were side effects. Most of them were mild or moderate, and most of them were GI related, very similar to what we hear from patients in the first week, 2 weeks, 3 weeks after surgical treatment. Now, the big breakthrough is going to potentially be tirzepatide. Now, this is a 39 amino acid structure that is based on native GIP, but it also binds the GLP-1 receptor. And it has a half-life of more than 5 days. And even in patients with renal and hepatic impairment, we can use this medication. So I'm just going to show you the SURPASS phase 3 study, a series of studies that were done, but look at the average reduction in body mass, reduction in hemoglobin A1C. Again, we're starting with 8.2 and we are dropping it down to below 6. Again, this is something that we've become quite used to seeing with bariatric surgery, but this reduction in hemoglobin A1C is very similar to what we would see after bariatric surgery. If we look at the weight loss at 40 weeks, we see 12% weight loss in these patients on average. But remember now, that doesn't tell us about the categorical weight loss. And again, we would expect more than 20 or 30% of patients actually achieving 20% weight loss. We see improvements in blood pressure, of course, systolic and diastolic, but we also see side effects. And as we go up with the doses of these medications, we see more side effects. But of course, with the benefit of the medication, we can reduce the doses and therefore reduce the number of side effects, or allow people to titrate it slower to not run into these problems. There is nausea, and the nausea can actually stop a number of patients from continuing with the medication. And you know, how we manage this nausea needs to be, we need to be clearer about it. And one easy strategy would just be to dose titrate a little bit slower. So I'm going to summarize and say, if you are normal weight, the more you eat, the more satisfied you would feel. If you have the disease of obesity, this is shifted to the right. But if we have interventions such as surgery or the new medication, we are shifting the curve to the left to allow people to have physiological changes. And how will we actually put this in practice? I think now what Camilo was saying was so true, that we are not approaching diabetes and obesity as the chronic diseases that they are, and stigma is holding us back from doing that. But what we need to do if we have a patient with obesity and type 2 diabetes, yes, we need more public health messaging, but if it does not work, we need to escalate to professionally directed nutritional therapy. We know whether or not this works within 3 months or not. If it does not work within 3 months, either change or escalate to pharmacotherapy. Now, the pharmacotherapy is going to be far more effective, as I've just shown you. But also remember what I pointed out with the categorical weight loss is that there's about 20% of patients that do not lose more than 5% of their weight. And what that means is, if we're going to start treating large number of people with obesity, because remember, we are penetrating less than 1% of the population with obesity right now with any treatment. If we start increasing it tenfold, what's going to happen is 20% of the patients that we are treating with these great drugs are not going to respond, but they are now entered into the space of having their obesity treated as a disease. And therefore, what I think is going to happen is these patients will be escalated to surgical therapy. So instead of many of the surgeons thinking that they will do fewer operations in the future, I think you're going to do far more operations, just because these drugs are going to change the way we view obesity. It's no longer going to be the patient's fault. It's going to be just another chronic disease that needs treatment. And of course, ultimately, many of our patients will need a combination of surgery plus medicine. So I think we need to get away from this idea that it's drugs against surgery and rather focus on this idea that it's drugs with surgery. So I'm going to conclude and suggest that overeating does not cause obesity, but obesity as a disease causes overeating. And when we treat obesity effectively with surgery or with these drugs, what we see patients report is that they naturally eat less food. We need at least 15% weight loss to really disrupt many of these diseases. And we've seen that's possible with surgery, but for the first time, it's also going to become possible with medication. And although it's demanding, double-digit weight loss should really be the primary target for the treatment of obesity, and especially with the complication of diabetes. So please allow me to thank the international collaborators, many of whom are on this call, as well as our team at home that's doing the hard work. So thank you very much, and I'm handing back to Dimitri.
Oh, thank you for this glimpse into the future, which looks great. And before Alex and Camilo ask you a question, I'd like to know, what are the challenges you're expecting to see in getting this amazing treatment into clinical practice beyond the cost and the infrastructure challenges?
Yeah, so I certainly think, just to spend a moment on that, that nothing is ever going to be cheaper than surgery. Surgery will always win on the health economic grounds that Camilo has already mentioned. And that's a very important point that we need to keep making to patients, but also to healthcare authorities. The other challenge that we have is which patients to treat. Now, we've done that a little bit with surgery, to prioritize patients, but we cannot treat everybody that has the disease of obesity, especially if the healthcare system is paying for this. These drugs are going to be very expensive, and I think ultimately that is going to be a limitation. But like all drugs, these drugs will become cheaper as time goes on, and therefore we'll be able to treat more people in the long term.
Thank you. Alex.
Yeah, so I was going to follow up with that and say I always give the example of proton pump inhibitors or even Viagra. When these medications came out, they were very expensive. You needed to see a gastroenterologist or a urologist. You need to have an upper GI endoscopy, all sorts of tests, and you needed to have brown shoes and blonde hair in order to be eligible to get them. And now you're able to buy both the proton pump inhibitor and Viagra over the counter without a prescription. And they are not that expensive. And I think this is what will happen to medications for obesity. We're just about 15 years behind, but it will come.
Great point, Camilo.
No, great talk, Carel. Very, very nice. I agree and disagree with two things in your talk. I totally agree that the main thing is that, and it's been our experience with very minimal invasive procedures like the balloons, for instance, the LIBSS balloon here in Chile that arrived just before the pandemic. We put 1,000 of them last year. And if you are really clear with the patient on what's going to happen, those patients understand that they are treating a difficult disease. And if they fail, they come back to you. If you are honest, saying, well, you have a chance of losing good weight, but if you are really honest with what's going to happen, the patients come back to you and they ask for the next level. If you come to them saying, no, this is the super treatment, you're going to be fantastic, nothing else is going to need it, you're going to be okay, the patients are angry with you and they go to someone else. But on the thing I don't agree, Carel, is that I think although you're going to have more patients wandering around, they are not going to be referred. That's my point. They're going to go straight to the surgeon, or they're going to say, come on, I've been like wandering around here with many things, and nothing's happening, and that's what we see. And I think drugs are getting really better. So definitely, especially, I think I've been discussing with many specialties, and I think diabetologists in particular, they are not used to surgery. As for instance, a cardiologist, that they're used to stenting, putting things up, and they're very used to that. So I think they're gonna continue to play with new things and new drugs, and I'm not sure. I'm speaking about referrals. We're gonna have more patients, I think, okay, but it's because patients are gonna ask for surgery, not because they're gonna send them.
So I think you are correct, but I would say there's an opportunity, because right now diabetologists are only used to failure, right? They've never been used to success, right? Now suddenly with these new drugs, they're going to have amazing successes, you know, people losing 15, 20% of their weight without trying. But none of us can predict which patients will lose weight and which patients will not lose weight. So for the first time, the diabetologists are going to taste the success, but now they're going to be faced, for every 8 patients that are very successful, 2 patients are complete failures, right? In old language, meaning that what do they do then? And this is, I think, where the surgical community have to offer the diabetologist, you know, say to them, listen, you're not a bad diabetologist, it's not a bad drug, but 2 out of 10 people are not going to succeed. These are the people that you have to send to me because I can make you look good, right? The tables are turning, right? And I think that is a way to increase, because if you're a diabetologist that have great drugs, can make 8 out of 10 people lose amazing amount of weight, but the 2 people that don't lose weight, you send to your colleagues, the surgeons, and they also lose a lot of weight. Now you've got 10 out of 10 people losing weight. Okay, but you are correct. We need to make those discussions happen, and we also have to have direct to patient, you know, information, because you are correct. Even in Europe, this is what drives referrals to an obesity clinic. It's not referrals from GPs, it's patients going to their GPs asking to be referred. So it is a challenge that we have to overcome.
Carl, I'm aware you'll have to go very soon. I'm going to let Chetan ask you a quick question before you go. Chetan.
Yeah, thank you. Just an exciting session, as you can imagine, and quite knowledgeable. A quick question, mainly, I think everybody was talking about cost, and Alex mentioned that we are maybe 15 years behind with the pharmacotherapy, and it will still take time. And I think in this COVID era, we are seeing a lot of our patients waiting, having gained weight. So if, as a surgeon, not really used to prescribing this medication, I had a choice to make, to give either to my pre-op patient or my post-op patient who had gained weight or failed to lose weight, is there any algorithm I would rather go for, that go for a pre-op with better results or a post-op for better results?
So what I would suggest, and it'd be interesting to hear Alex's opinion later, but what I would suggest is that we use a lot of medication pre-op to make the surgery easier, to reduce length of stay, and to effectively facilitate surgery. But if you can operate on a patient at the weight that they are now, then there's no need for the drug. It's not, the patient's not overall going to lose more weight. So if the patient starts at 100 kilograms and they would have ended at 70 kilograms with an operation, if you give them a drug, they go from 100 kilograms to 90 kilograms. If you do an operation, they still end at 70 kilograms, right? However, what Alex has shown, and he's going to talk about that now, if you add the drug after surgery, you get additional benefit, right? So you take them from, so if they go from 100 kilograms to 70 kilograms without the drug, Alex is going to show, if you then give them the drug, then they go to 65 kilos, right? So that's the, so there's not an algorithm, but it's just, you know, where you use it. But this drug is really easy to use by surgeons. You know, any doctor that can write a prescription can use these medications. They are not difficult to use. And I think we really need to get these drugs into the community in the very near future. Of course, there'll be a little period where we need to sort things out, but we very quickly have to move these drugs into the community.
Carl, thank you very much. I know you have to go. Alex is going to talk exactly about that now, about what to do with medications and surgery for the inadequate response. Alex.
Dimitri and Sanjay, thank you very much for inviting me. I am a diabetologist, but I feel very comfortable in your company. So diabetologists do have a heart, they also have a brain, but it is stuck in 1921 when insulin was discovered, I'm afraid. But the newer guys are getting better. So let me just tell you quickly some of my thoughts, and I think I'll stick to time. You can see my screen?
Yes.
Good. So I don't think that as surgeons you've done a bad job. I know there are some mavericks and in terms of how you sell things, but you guys, you've done trials, you've spoken at very good meetings. So I don't think there is much more than you can do to be fair. What is now, we have 10-year data for the effects of gastric bypass and BPD, and the only thing that you're seeing here is that as time goes by, the number of people or the percentage of people who have got this diabetes remission gets less and less, which is absolutely fine. This is what we would expect when we give someone metformin, right? So in my mind, surgery is just another drug. And just not being able to achieve remission in a significant proportion of people in the longer term, well, at the moment at least, is certainly better than what I can achieve with any pharmacotherapy. So surgery is still the most effective treatment. And the only thing that we need to do is we just need to enhance it and make it even better, okay? And with regards to diabetes remission, not diabetes remission, to be honest, I couldn't care less as long as the patient lives longer and they have better quality of life and fewer cardiovascular events. So this is the first randomized clinical trial that has been performed on the use of GLP-1s after surgery. In fact, any pharmacotherapy probably after surgery. Remember, this is now the metabolic angle of the surgery. So these are people who had diabetes and either they relapsed into diabetes after gastric bypass and sleep, or they never achieved it. So what we did was very simple. We just gave them either liraglutide 1.8 milligrams once a day or placebo for 6 months in double-blinded fashion, and what we saw was that liraglutide worked very well and it was safe. It reduced HbA1c by about 1.1% and body weight by about 5 to 6%. Now, this is exactly what liraglutide does in people who have never been operated. And there are different hypotheses as to why this may happen. But it is almost as if the patient has never had an operation. This is how liraglutide works after these procedures. And that will gradually bring me on to some practical points that I want to share with you, following on to what has been said before. And as always, even after surgery, even after you added the medication, the variability is still there. So you'll see some people that respond very well and some people who do not respond at all. And then if they do not respond, then it means that you need to stop liraglutide and give them something else. This is the typical variability of response, which demonstrates that this is a biological disease. Now, we have got additional evidence for the use of the combination of surgery with medication from Said Ikramuddin's RCT, which is not unfortunately very much presented, and I keep presenting it because I think it's great in the impressive effects, first of all, that are achieved with a combination of, it's not just Roux-en-Y gastric bypass, it's Roux-en-Y gastric bypass with a lot of medications or pharmacotherapy or lifestyle interventions. Very impressive reductions in all of the markers that you're seeing. And what I love about this paper is the title. It doesn't say bypass versus this. It says lifestyle interventions and medical management, which is what all patients have, with or without the gastric bypass. It's a beautiful title, and it shows that we're just adding a gastric bypass pill to the patient's medications. And that's the way that I see it. That's why we wrote with Carel this editorial and call it the medical gastric bypass, which has confused a few, but this is effectively what it is referring to. Now, from a very practical perspective, and I will be talking about that also tomorrow to the allied healthcare professionals, just for my diabetology colleagues or the surgeons even that are looking after these patients, do not be worried, do not assume that the management of these people after surgery is complex. It is very, very simple. We like to make it look complex to make us look smart, but it's not. So assume that when you do your operation for the patient with their diabetes, you as a surgeon have just pressed the reset button, reset to initial settings. And then the patient comes to you with a new diagnosis of diabetes. And then what you do, well, in the early stages, you need frequent contact because you don't know how they will respond, all right? So you will be playing around with their fasting blood sugars. Now, then if the blood glucose is not controlled in the medium or certainly longer term after surgery, just treat the patient in any other way that you would treat them. And this is just, I'm going back and forth in the slides. These are the ADA and ESD consensus statements of 2018 on how to treat people. Just follow that in the same way that you're following it in people without, nothing smart. And we can give metformin, you can give SGLT2s, you can give anything you want in the same way that you did before surgery, all right? There is nothing stopping you from using any of these medications. Well, I say that, I don't have RCTs to tell you that, but I have got quite significant experience myself, but also many colleagues are doing it around the world. I know this is not hard evidence, but I would like to reassure you about the simplicity and safety. The only thing to say is that if you're going to use an SGLT2 inhibitor, I try to avoid it within the first 3 months after surgery, because there are too many to make many changes taking place, and you don't want someone to develop a ketoacidotic picture. And the other thing to say, which I think is important, now that is slightly different, is that I keep patients who have got established cardiovascular disease or kidney disease, I keep them on their SGLT2 and GLP-1 independently of what their glycemia is. I'm doing that without evidence, all right? This is my own practice, and I'm doing it because I know that SGLT2s and GLP-1s have got their very important role in the prevention of deaths and then the prevention of heart attacks and strokes and dialysis in these people who have not been operated. I'm just extrapolating that data. And Dimitris is actually doing an RCT called BiPlus, which combines pharmacotherapy with surgery, and will examine at least some of those outcomes. So yeah, this is the protocol. The recipe is the same. Finally, if you do want to use pharmacotherapy for weight loss rather than glycemic control, you can use Saxenda, liraglutide 3 milligrams, and you'll see there's not a huge amount of evidence from that. It's not RCT studies, and you're going to see again that the weight loss that Saxenda causes after these operations is exactly the same as if the patient has never been operated. That's it from me. Thank you very much for the invitation. I hope we stick into time, and then this is a good time to have another chat.
Alex, thank you for a brilliant talk, and thank you for getting to the nitty-gritty on how to manage these patients. Question from Cynthia Borg from London. Are there these patients with severe obesity but who are normoglycemic?
Oh, yes, I think UCL are doing a trial on that, using GLP-1s in people who have got a poor GLP-1 response. If I'm not mistaken, this is in patients who do not have diabetes, and I think that's an RCT. Whether there are any other ones taking place, I would be surprised, because it's not easy to get funds for those kinds of studies.
Indeed, and you're absolutely correct about the BariOptimize study, and indeed there's people without diabetes with a poor GLP-1 response. Camilo, a quick comment before we close.
No, excellent talk, Alex, and it's fun because we see that different types of diabetologists, and you're the one I like, though. But I think what would you suggest would be our next step from the surgeons towards the diabetologists to make our relation more close in terms of Because I feel
I honestly think, despite some mistakes made, I think that the metabolic surgery community has done a very good job. Okay, diabetologists are very conservative people. I work with them any day, and I cannot many times stand them. All right, so the only thing you do is you get, as Carlo was saying, you get into the picture, and you say, because initially. Now with the successes, some of the will say, "Well, I always knew it. You know, we're going to fix this ourselves. We don't need these guys," as I always thought. But the patient will come back, and they will come. Now, what you need to do is you need to tell them not to keep trying the same thing again and again and again as they have been doing before. And they should get their minds unstuck from 1921, but just get into that space of those people that do not respond, and they need more help. And you say, you know, these people are in the system. I am the next step, so why not? But I think I must say, the newer generation of guys, they are not like the people that speak in meetings at the moment, and excluding me, of course, because I'm very young.
Alex, thank you. Camilo, thank you. It's been a provocative session. I think we have demonstrated that metabolic surgery may be dead as we know it or as we knew it, but long live metabolic surgery in an evolved way, winning people's hearts and minds, and providing better care for patients with and without diabetes, but definitely with a severe and complex obesity. Thank you very much. We're bang on time. I think we managed to catch up, and I'm going to pass on back to Sanjay. Thank you all.
Thank you, Dimitri. I can definitely see and hear you have justified the title, and I'm very pleased. I'm sure all the 500 delegates would have liked it as well. We will close the session now, and we, if who are not having, can we go to the industry sponsor session? So we will stop the streaming, and then we'll move to the industry sponsor session now, and we'll rejoin the main session at 1:30 London time, please. Thank you.